All right, if you're prepping for the AFK exam, you are in the right place. This is your high-yield, no-fluff guide to dental implantology. We're going to cover the core concepts you absolutely have to know to nail those questions.
Here's our game plan. We'll start with the science, the very foundations of how implants work. Then, we'll dive into treatment planning, where all the critical measurements happen. After that, we'll walk through the surgical workflow. And finally, we'll cover how to know if you've succeeded, and wrap it all up with a rapid-fire recap.
Okay, first things first, let's lay the groundwork with the fundamental principles. These are the ideas that make everything else we're about to discuss even possible. Understanding this is key. So, at its simplest, what exactly is a dental implant? Well, think of it as an artificial tooth root. We sometimes call it an endosseous implant or a fixture. It's a surgical component that we place into the jawbone, where it acts as a super sturdy anchor for a future crown, bridge, or even a denture. And that leads us to the magic word in implantology, osseointegration. Honestly, this is the whole ballgame. It's not just that the implant is sitting in the bone, it's a direct biological fusion, a living connection between the bone and the implant surface. This process is the entire reason implants are so stable and can handle chewing forces. So every implant system, no matter the brand, boils down to these three parts. You have the implant body or fixture, that's the part that goes into the bone. Then you have the abutment, which is like a connector piece. And finally, you have the prosthesis, the part you actually see, the crown or bridge that the implant supports. Okay, let's switch gears to treatment planning. And let me tell you, this is where you win or lose. A successful outcome is decided right here, long before you ever touch a handpiece. It is all about the measurements and really understanding the patient's anatomy. So that begs the question, right? What are we looking for in an ideal implant site? Well, it really comes down to two main things: the amount of bone you have to work with, the quantity, and just as critical, the quality of that bone. And this chart is brilliant because it lays out bone quality perfectly. You might think that super dense D1 bone is the best, but it actually has poor blood supply and can easily overheat when you're drilling. On the flip side, D4 bone is just too soft. The sweet spot, the absolute ideal bone for an implant, is D2. It gives you that perfect mix of a solid outer layer for stability and a spongy, well-vascularized core for fantastic healing. Now, beyond bone quality, there are some hard and fast rules about spacing. Think of these as non-negotiable safety zones. You have to respect them to avoid major complications and to make sure the tissues stay healthy for the long haul. Let's break down the key numbers you have to know. Rule number 1, and this is a big one. You must always keep a 2 millimeter safety margin between the tip of your implant and the inferior alveolar nerve. This is absolutely non-negotiable. You do not want to risk nerve damage. Next up, horizontally, you need at least 1.5 millimeters of bone between your implant and the root of the tooth next to it. Get any closer, and you risk choking off the blood supply and causing bone loss on that healthy, natural tooth. Okay, another nerve to watch out for. The inferior alveolar nerve often does this little anterior loop before it exits the mental foramen. To be safe and stay clear of that loop, the standard of care is to place your implant at least 5 millimeters in front of the foramen. And for aesthetics, this number is everything, especially in the smile zone. To avoid that ugly black triangle between teeth, you want the contact point between your crowns to be no more than 3 to 5 millimeters from the top of the bone. Any more than that, and the gum tissue, the papilla, just won't fill in that space. All right, planning's done. Now we get to the fun part, the surgical sequence. We're going to talk about how we prepare the bone and the super important concept of how an implant gets its stability over time. So preparing the bone site, what we call the osteotomy, is a very systematic process. You start small with a pilot drill to set your position and angle. Then you pop in a direction indicator pin and take an X-ray to make sure you're on the right track. After that, you just gradually widen the site with a series of larger drills. If you're in that dense D1 or D2 bone, you'll use a bone tap to pre-cut the threads before you slowly insert the implant with low speed and very controlled torque. Now pay close attention here. This is an absolute must-know number for the AFK exam. If the bone gets hotter than 47 degrees Celsius for more than a minute, you will kill it. It's called bone necrosis, and your implant will fail, period. That is why we use tons of saline irrigation and always use sharp drills, to keep things cool. So, once the implant is in, its stability changes over time. Right at the beginning, we have what's called primary stability. This is purely mechanical. It's just the friction of the implant threads gripping the bone. But over the next few weeks, as the bone starts to heal and grow onto the implant, that mechanical stability actually goes down while the biological or secondary stability starts to ramp up. And this handover from mechanical grip to biological bond creates this really vulnerable window we call the stability dip. It happens around 2 to 4 weeks after surgery. It's the point where the initial stability has faded, but that new bone growth hasn't fully taken over yet. This is when the implant is at its weakest and most at risk of failure from tiny movements.
Okay, we're in the home stretch. Let's talk about how we actually define a successful implant in the long run, and then we'll pull together the most critical takeaways for your exam.
You need to know that implant health isn't just a simple pass-fail. It's a spectrum. A truly successful implant is rock solid, has very little bone loss, and healthy gums. As you start to see more bone loss or deeper probing depths, it moves into a satisfactory or compromised state. But the absolute red line for failure, that's any mobility at all, pain when the patient bites down, or more than 50% bone loss. At that point, it has to come out. So how do we help preserve that precious bone right at the top of the implant? Well, one clever design concept is called platform switching. It's simple. You use an abutment that's a bit narrower than the implant platform itself. This shifts that tiny gap between the two parts inwards away from the bone, and that little shift makes a huge difference in maintaining soft tissue health and reducing bone loss. So let's quickly recap what a healthy, fully integrated implant looks like. It has to be clinically immobile, no wiggling. On an X-ray, there should be no dark shadow or radiolucency around it. After that first year of healing, any annual bone loss should be less than 0.2 millimeters. And remember this, unlike a natural tooth, probing depths up to 5 millimeters can be totally fine around an implant as long as there's no bleeding or infection. All right, this is it, your AFK cram sheet. Get ready to screenshot this. D2 bone is ideal. Your safety zones are 2 millimeters from the IAN, 1.5 from teeth, and 5 from the mental foramen. The stability dip is at 2 to 4 weeks. Keep your insertion torque under 35 newton centimeters and the bone tent below 47 degrees for 1 minute. Success means less than 0.2 millimeters of bone loss per year after year 1, and remember that probing up to 5 millimeters can be perfectly healthy. So, let's end with this thought. We've gone through all the numbers, the rules, the criteria for success, but what does it all really mean? It shows that modern implantology isn't just about sticking a replacement tooth in a hole. It's about meticulously recreating a functional, stable, long-term biological system. And that, right there, is the real challenge and the real reward.